This week we'll be looking at gestational age and behavioral assessment. So anytime we have a newborn, we're always assessing for just a basic general appearance. So part of that is looking at posture, which can be determined by gestational age. This week we'll be looking at gestational age as well as behavioral assessments for newborns. So when we're first getting started looking at a baby, we want to take a look at their general appearance. So their posture is determined by their gestational age, and it can also be determined by their intrauterine positioning. So with preterm babies, we see that they're more open, have more extended positions, they're not as well flexed. So that's this middle picture here. And then this would be examples of how you could chart it. So low flexion, consistent with gestational age, for example. Whereas term babies are more contained and tend to be in more of a flexed position with strong flexor tone. So well-flexed term infant would be a way that you could describe the general appearance for this newborn. General appearance, you could also put color. So pink, well-flexed term newborn, something like that would work. And then here we see we were definitely breech in utero. So posture consistent with breech presentation could be something you could note for a gestational appearance for this baby. And just to pause here, you'll notice the baby's head, because it wasn't squished in that classic vertex, well-flexed position coming out. You don't see that kind of egg-shaped head on this baby. And it even looks a little bit flat or scooshed in the other direction, and that's because contractions can kind of shape the head that way in labor. So I think sometimes that can almost look alarming to see it that way. You might wonder if something else is going on, but it's just the way contractions impact baby's head in labor. And that would be the same too, if you had a mom come in and she'd been laboring for a while and then that baby ended up going to C-section, you might still see that head shape that way if mom had been in labor for a while. So basically with low tone, it can be semi-normal or expected if it's preterm, but if you have a term baby that's not showing very good tone, then that's something to potentially be concerned about. So moving on then, looking at gestational age assessment. So we're going to look at gestational age assessment and then we'll go to behavioral assessment. So gestational age assessment, why are we doing this? So whether you do a full-blown Ballard scale assessment where baby ends up with a number that corresponds with a certain gestational age, or whether you're just being cognizant of the items on the gestational age assessment scale as you're doing your newborn exam to just ensure that there's a good general gestalt for this baby to meet up with what everybody was expecting. So you have a 39-weeker, you're doing an exam, and your findings are essentially consistent with a 39-weeker. There's not necessarily a reason to do the full-blown gestational age assessment. Either way, why are we doing it? So the first reason would be that we want to identify any neonatal risk and develop a management plan if it looks like baby is more preterm. So we know preterm infants, it's harder for them to stabilize their blood sugars, as well as just their respiratory development. They're more prone to respiratory distress or apnea. They're also more prone for hyperbilirubinemia, as well as having feeding issues. Just thinking about their neurological development and everything that's needed neurologically for breastfeeding. That pretty much checks off just about everything on your neurological exam if you watch a baby feeding really well. So sucking, rooting, all of those pieces. But then also just thinking about if their mouths are a little bit smaller, that can make it harder for them to get a good latch, etc. So wanting to be able to be to have those pieces in mind on the front end can help ensure everybody has a better transition if you are a little bit on the not even just thinking if we're 37 weeks versus 40 weeks, just those subtle differences. And then certainly if it's less than 37. Okay, and then the second reason would be accuracy needs to be essential for clinical trials. So say you were one of the providers as part of a water birth study, and whether your baby had good outcomes or not. If you caught a baby that was expected to be full term and then you do the exam and it's like, ooh, I think our dating really was off here, then they should probably be excluded from the trial. So most clinical trials, just in general, aren't going to want to have pretermers included, since that's an independent risk factor in and of itself. So how do we determine gestational age? So we've been talking about doing the newborn physical exam, but also last menstrual period. You know, I caught a 39-weeker. Unless your exam is way different from that, I'm expecting that you're essentially a 39-weeker, right? So that could be done from last menstrual period or possibly conception. If it was ART, you might be able to really pinpoint the date that way. So something along the lines that happened right at the beginning. And then we also have obstetric parameters. So certainly that first trimester ultrasound when you have a crown rump length, that's going to be your most accurate for determining dating. If you don't think, like if a woman doesn't have irregular menstrual cycles, etc., then that crown rump length really is your next best. So I don't know how much you got into this in antepartum, but just speaking as somebody who does limited ultrasound, if you have a crown rump length, that would definitely trump a fetal pull, which you would see first. That's basically just measuring, this is the little blob that we've got as a person in here, and we can't make out anything yet. And then ideally, if that's what you're measuring for an age, you're having them come back in another week or two so you can actually get the crown rump length. And then really outside that first trimester, you're really tracking growth. You're not trying to determine baby's age. You're determining where baby falls on the growth scale, right? So, so you might need to do that if, say, you're working with an immigrant population and they didn't have previous prenatal care, and the best you can do is a second trimester ultrasound. That might be the best thing you've got, and then in that kind of a situation, you definitely want to do a newborn exam. And then lastly, doing a newborn physical exam would be another way to determine gestational age. So, and I already alluded to this, but it's not typically done routinely unless it is preterm, or unless, as you're just starting to do your newborn exam, it's looking quite a bit different than what you were expecting. So I would recommend, so basically our Ballard score here, we've got our Ballard score is part 1 and then part 2. So I'm going to walk us through both, but I thought better to put it on 2 slides so that you can see it better. But I would really recommend, if you feel game for it, as a student, anytime you're doing a newborn exam, just include this. When you go into newborn nurseries and are doing a bunch of exams on all the babies, the more you can do this now, then the more you can just intuitively incorporate some of these elements into your routine exam, just as a little double check to what you're already expecting. And then if it seems like it's way off, then you're going to whip out the full-blown scale and you're going to do all of it. But otherwise, just to really be familiar with these pieces of the exam, I think it would really help if all your newborn exams as a student you were doing this. And then that can be more of a part of your practice to recognize what pieces would be considered more preterm versus term. So basically, the way this scale works is you start by manipulating baby in a bunch of ways for this first half of the scale, and then for each thing that you do, baby gets a number. So what I like to do is I would just print out a bunch of these, really easy, just Google New Ballard score, print out a bunch of these, and then bring one to the bedside, and then you can just circle which one they are, and then add up all your numbers from there. So for this one, first thing you're doing is evaluating baby lying down. So you can see here this would be pretty preterm posture. We're hardly flexed at all, right? Versus a little bit of flexion, a little bit more flexion. This is more classic newborn into late term, but honestly more newborn. So either of those we would expect probably for our term babies. And then you're taking baby's hand and you're bending it at the wrist. And you can see that the more term they are, the flatter their hand can lie against their forearm. Okay, and I just want to say your book is excellent at this for showing you pictures, because these are just the little crude diagrams, but you pull this up in your book, look through those, familiarize yourself with those, and that'll give you a really good start. So then you're looking at arm recoil, so basically you're having baby kind of hold your hands, and then you're pulling baby up and letting go, and then you see how their arms recoil and what's their default arm status. So similar to posture, but then you're prompting baby to get into their default posture, if that makes sense. And then popliteal angle, you're going to keep baby's bottom against the bed, but then hold their feet up and see basically how far it naturally is going to go. So is it toe to nose? And it's really not, well, that's sort of similar to heel to ear, but here we're looking at the angle of baby's knee. So if we pull it back, what is their angle? Are they staying pretty well flexed, or does it go pretty straight? And then just because this is pretty similar, if I'm doing one of these, I'll just do these two together. Does their heel go all the way to their ear? Almost there, and then less and less. And again, this is with their sacrum against the bed, so it's not like you're rolling them up in a ball. And then scarf sign, basically keeping both baby's scapula against the bed, so they're laying on their back. You're taking one arm and you're pulling it to the other side of their body. And again, we're not pulling baby such that we're rolling baby up. Their back is against the bed, and you're pulling their arm over, and then take a peek where this baby's elbow is. So this elbow is way past baby's body, just past baby's body, just to the edge of baby's body, more like their midline. Really doesn't go far at all, and is even further that way. So you just circle what they are for each of those. And I was going to put in a bunch of pictures of examples, but it's harder for me to find Google Images, and your book really has fantastic pictures. So I really would peruse those pictures, print out a bunch of these, and then just get started doing them when you're in clinicals. Okay, so here's part 2, and when you print it off, this will all come up on one page. And hopefully you can read these. I'm hoping it doesn't show up too blurry on the PowerPoint, so I apologize if it does. And if it does, I would say print one out and follow along with me that way. But basically, we're just going to look through these next criteria. Oh, and what you can't tell here is that these line up underneath the other one, so the scoring of 1, 2, 3, 4, 5, etc. Aligns with that part 1. So they're getting a number score for each of these. So for skin, is it sticky, friable, transparent? So that would be consistent with more of a preterm, all the way to maybe a little bit of peeling, maybe a little bit of rash, a few veins, but we're not transparent anymore, versus having cracking or really deep cracking for our post-term babies. They get extra points. And then you're taking a look at lanugo. Is there none, sparse, a ton of it, lanugo that's now thinning, lanugo that now has bald areas, or mostly bald? You can really see how baby developed to go from none to back to bald. And then we're looking at the bottom of baby's feet, the plantar surface. And you want to basically see how crinkly is it. So on the term end here, we'd see that creases cover about 2/3 of the foot versus creases covering the whole foot versus just a few faint red marks. And then you look at their breast buds, and if you can't even find them, that's really consistent with a preterm baby. Then otherwise, you've probably got your little tape measure there to measure head and chest circumference. So go ahead and whip it out. And then if it's a 3 to 4 millimeter bud, that's this many points. This is a 1 to 2 millimeter bud. So you're just feeling their breast, and it should feel, I don't know, like a breast bud. Okay, now we're going to look at their eyes and their ears. So let's come over to term, because on that end, lid's fused. What are the chances we're assessing that baby? So basically, you want to see how well their ear coils. So if it's formed and firm, instant recoil, we'd expect that with a term baby. If it's really thick, recoils super fast, you might give them an extra point there. It's like it's stiff, versus maybe a little on the earlier side. It's well formed, but it's kind of soft and it recoils, but not an instant recoil. So you can kind of see that spectrum there. And then the last bit, you're either doing genitalia for male or female. So for males, it's basically about looking at if both of their testicles have descended and if there's a decent amount of rugae covering their scrotum. So deep rugae versus good rugae versus few rugae. But all of these more term ones would account for having all the testes descending. Well, both the testes descending. And then for girls, you want to see that the majora are large and the minora are small, which is basically mom's estrogen kind of swelling them up. But if the majora totally covers the clitoris, then that would be a slightly higher score. And if the majora and the minora are about the same size, then that's a little bit of a lower score. So just to kind of think about the spectrum there. And then you add up your score, and then that's going to fall somewhere in the realm of a 38-weeker or a 40-weeker. So you add up your numbers and you see what you get there. So that's just a brief overview to gestational age assessment. Not too tricky, but nice to just get in the rhythm of doing them. Okay, so behavioral assessment, you want to consider their perinatal history. So gestational age certainly plays into that. You know, if you've got a younger baby, you're going to expect a little bit of a different assessment. How old is this baby? Were they born an hour ago? Were they born 4 hours ago? I would expect their behavior to be a little bit different based on that, right? Type of labor and birth, certainly. Was baby stressed out towards the end? Was this a C-section or a forceps birth? Did baby need a little bit of a jump start? Were mom and baby separated for a little while after the birth? So you're keeping all of those pieces in mind. And then was mom on any medications, whether that's in pregnancy, maybe like an SSRI, versus maybe any medication she might have received for labor coping, that sort of thing. And then you also want to consider the current environment baby's in. So ideally for assessing behavior, you'd like it to be a warm, quiet, softly lit room, and ideally with caregivers present. So for the behavioral age assessment, or not behavioral age, sorry, just behavioral assessment, I like to just basically do this while I'm doing their normal newborn exam. So ideally you're starting out with baby either being asleep in mom's arms or maybe like a quiet, awake mood, and then you can listen to baby in that position, just doing heart and lungs still in mom's arms, and then as you're considering what pieces of your exam you're doing, you're thinking about the order of it from being least invasive to most invasive. So least invasive being things like listening to baby's heart and lungs and bowels, and then a little bit more invasive is feeling baby's head and checking that her clavicles are intact, that sort of thing. And then more invasive would be like checking testicles to see that they've descended, and then most invasive I would think of, checking for hip dysplasia. Most babies don't like that. And then by then I might even see baby crying, and then in doing that full sequence I've been able to see most of babies' behavioral states. So just to be mindful of that as you're doing your exam. So here's our behavioral states. So we have a deep sleep, light sleep, drowsiness, quiet alert, active alert, and crying. And ideally, we're hoping that we can assess basically all of those and see that baby's able to smoothly transition between states. And then when they're in any given state, they're organized in how they're going about it. So basically, it's helping us understand how baby's coping with their surroundings. So do they interact with their surroundings in an organized way? That's how I think about it. So for deep sleep, I'm not expecting to see any activity, really regular breathing. That might be when I start my exam. And then I kind of don't like to do that because I feel like if they're that comfortable, let's just keep them that comfortable. That's unimportant. Okay, side note. So then for light sleep, low level of activity, you might see some rapid eye movements. That's a nice time to start your exam, listening to heart and lungs. And then drowsy, that could be on the way in or on the way out. Variable activity, you'll see their eyelids looking heavy, might kind of slowly be opening and closing. And then for quiet alert, they're usually bright and wide-eyed, and they can focus on whatever stimulus might be in front of them. So active alert, they start having more activity. There might be some periods of fussiness there. You might see some irregular respirations. And then for crying, you're more likely to see color changes, really increased motor activity. And then, their degree of stress or frustration, as well as their degree of energy, will affect it. So if you have a preterm baby, or if you have a baby that's a little bit sick, how much energy can they actually put into crying? So just thinking about that. Yeah, and for pretermers, as well as sick babies, it can be more difficult for them to maintain alert states. So it's expending energy for them to be able to maintain interaction, and they're more likely to show stress sooner as well. So responding to their stress encourages trusting relationships, and you may even need to do your newborn exam in a couple different segments based on baby's stress level. And then you can also just be watching for self-consoling motions. That's a sign of maturity. So if baby's crying while you're checking baby's hips and they're bringing their hand up to their mouth to suck, that's a sign of maturity right there. And I like to point these stages out to parents. Certainly the more verbal you are during your exam, that's including families, and a great way to educate families too. So even just pointing out, like, oh, that's such a good sign of maturity, see how they're able to calm themselves down. All of those pieces helps incorporate the family. So I was trying to find a variety of behavior states here, but I don't think I have all that many here. This one kind of looks like a quiet alert to me. Well, bright-eyed and bushy-tailed. This might be a quiet alert too. Kind of hard to say without watching baby. Might be quiet alert, might be drowsy. This could be light sleep or deep sleep. It's kind of hard to know. I think this one looks like a deep sleep. And then this looks like we're drowsy. But we might be quiet alert. I can't quite tell if this eye is half shut. So, hard to tell, frozen in time. So I'm just going to pause on this slide and see if you can think about for each one of those what they would be. I think you got it. Okay, we're going to keep moving, but you can pause if you want more time to think about it. And then just one more touch on crying. So normal term infants, we're expecting a nice, lusty, robust cry that oftentimes will have gross motor movements. So lots of good flexion here. That's a really fresh baby. So high-pitched crying is oftentimes with drug withdrawal babies, or if there's some kind of a CNS abnormality. Mewing, you might think about genetic abnormalities if it sounds more like that. Weak cries, it's like they don't have that much energy. So thinking about, might this baby have something else going on with the weak, feeble cries. So that's all I've got for us for this week. Hopefully you've stuck with me and you're not all looking like this baby. But if you have any questions, feel free to post it to the general forum. Otherwise, I hope you all have a great week.